Welcome to the 2025 Advanced Education in General Dentistry Graduation Ceremony and Patient Care Conference. Every year, our outgoing residents have the opportunity to demonstrate the skills and techniques that they have honed over the course of the past year. We will hear from them a little bit later. Before that, though, I would like to introduce you to this year's commencement speaker. When looking for a speaker this year, we put out a survey to our legacy residents, and they overwhelmingly suggested our guest speaker. Without further ado, I would like to introduce Dr. Mark Costas.
Hello, everyone. It's an honor to be here today to celebrate a significant milestone together. First off, I'd like to congratulate each of you for this defining moment, having successfully completed your program. And secondly, I'd like to express my gratitude to the doctors and facilitators of the Wichita State University AEGD program, Dean Elledge and Drs. Parth Patel, Brent Williamson, and Michelle Soma for putting this incredible program on my radar. My name is Dr. Mark Costas, and I am a 2002 graduate of the Marquette University School of Dentistry. Dentistry has been very good to my family and I wholeheartedly believe that it is one of the greatest professions that you could have selected to pursue and practice for your chosen career. So make sure that you take some quiet time to reflect on your accomplishments, and more importantly, how you want to design and architect your bright and beautiful future within this profession. And I'd like to repeat and emphasize my last statement because I believe it's that important. You and only you have the ability to design and architect what your future in dentistry looks like, and this day marks not the end of your educational journey, but just the beginning. During my 22-year clinical career, I was able to start and acquire a total of 16 dental practices. I'm the founder of the Dental Success Institute, co-founder of the Dental Success Network and the Colorado Surgical Institute, and I host the Dentalpreneur Podcast, the largest podcast to the dental profession with listenership in 151 countries, over 2,000 episodes, and closing in on 11 million total downloads. I don't say any of this to brag, but rather to highlight the fact that during my journey, I've made just about every mistake you could possibly make in the areas of business ownership, partnerships, leadership, human resources, capital allocation, and work-life balance. And I definitely prescribe to the philosophy in the quote by Warren Buffett when he says, "It's good to learn from your mistakes. It's better to learn from other people's mistakes." So today, during my brief talk with you, I'd like to share some of the biggest lessons that I've learned in the trenches as a clinical dentist, business owner, and dental performance coach. Lesson number one of the most important skill sets that you can develop in order to significantly increase your likelihood of success in the dental profession is your ability to communicate well. Your communication ability will have a direct impact on the level of trust and rapport that you can establish, as well as the depth of your personal and professional relationships. And the quality of your relationships is directly proportional to your success in every aspect of your life. Do whatever you have to do to become a master communicator. Lesson number two, whether you are a dental associate, a dental practice owner, or hold some other position in our profession, in order to become truly successful, you must continually evolve as a leader. Commit to developing into a strong leader. Read books, listen to podcasts, get a mentor who you can learn from and emulate. Never discount the value of this skill set. Develop it and it will serve you for a lifetime. Lesson number three, learn to understand business. I get it. We're clinicians, physicians of the oral cavity. If we focus hard on developing our clinical skill sets, everything else will take care of itself, right? While I agree that ongoing clinical education and development is obviously very important, I also believe that learning and developing business acumen is very important as well. If you decide to go into business ownership, learning how to become a more sophisticated business owner will significantly decrease your stress and significantly increase your personal take-home income. If you decide not to own your own business, understanding the business fundamentals of dentistry will allow you to be your own advocate when it comes to compensation and helping to create a positive work environment. Lesson number 4, define your non-negotiables. There will be seasons in your dental career when you'll have to work long hours and make hard choices on where you're going to allocate your time and energy. At one point in my career, after I had accumulated my first 6 dental practices, I found myself working 60 to 80-hour work weeks in an effort to work a full clinical schedule and drive to multiple locations while simultaneously managing over 50 plus employees. During that same period of time, my health declined because I was eating too much fast food for convenience, getting poor sleep due to stress, and wasn't setting aside any time to work out. My personal relationships were strained, not just because I was gone all the time, but when I was actually present, I was preoccupied and impatient. Those were some of the toughest years of my life, and while from all outside appearances, I looked like the picture of success, I was actually stressed, exhausted, and miserable. The saddest part about this story is that some version of the story is extremely common in our profession. In order to learn from the mistakes of so many of your colleagues that have come before you, my advice to you would be to schedule in your non-negotiable personal and family time and be disciplined about not allowing your professional obligations to bleed into your personal time. Lesson number 5, understand your personal finances and develop a plan. Make sure that you interview and vet out a competent fiduciary that will help guide you in the areas of personal finance, retirement and estate planning, loan repayment, and overall fund allocation strategy. Don't fall into the overconsumption trap and live within your means. Lesson number 6, don't try to do this alone. There's simply no better way to accelerate your personal and professional growth and development than to surround yourself with people who have already achieved what you want to achieve. Get a mentor or coach. Join a community of like-minded positive people. Create a wolf pack or accountability group. Add value to their lives, and they'll add infinite value to yours. And finally, lesson number 7. Never, under any circumstances, throw your colleagues under the bus. Develop a personal policy of never speaking negatively about a dentist, another dentist's team, and especially another dentist's clinical work. In my opinion, there is nothing more unprofessional or damaging to the profession than criticizing another doctor's work to a patient, your team, or anyone else. Keep in mind that regardless of what you see visually in the x-rays or in the scans, you never know what happened in that operatory. You weren't there, so keep your comments to yourself. In conclusion, once again, I'd like to sincerely congratulate each of you on an incredible accomplishment. The beginning of your dental school journey was like the seed that was planted for your career that has finally grown into a tree. Take care of it with plenty of water and sun and attention and love, and it will bear fruit for you and your family for a lifetime. Wishing you all the very best as you enter this new chapter, and remember, your future and your final destination is in your own hands.
Thank you, Dr. Costas. Next up is our resident presentations, beginning with Dr. Nick Desch.
Hi, my name is Nick Desch, and this presentation on some local anesthesia tips and techniques should be quick and painless. First, a little about me. I was born and raised in Topeka, Kansas, attended Kansas State University for my undergraduate degree, go Wildcats, and attended the UMKC School of Dentistry. Here's a picture of me with my fiance, Christina. Fun fact, we met our first year of dental school, and she's currently a dentist also practicing here in Wichita. Here I am with my dog, Bosco. He's like a little brother to me. And I am very excited to now call Wichita my new home, as I will be practicing as an associate on the west side of town after completion of this program. Now, let's get into some local anesthesia. This is commonly one of the most anxiety-inducing experiences for our patients, so I think it will be especially relevant to refresh our knowledge on a few key do's and don'ts, as well as share some helpful tips and techniques that we use here at the AEGD to make our local anesthesia as quick and painless as possible. Our first do is aspirate multiple times while injecting for PSA blocks. The PSA block is a commonly used block because it is easy to achieve profound soft and hard tissue anesthesia in its targeted tissues. It is a safe block with a low positive aspiration risk of about 3% compared to others such as an IA block with a 10 to 15% aspiration rate. But it is also easier to cause a hematoma because the injection site of the PSA nerve is surrounded by vascular tissue. Additionally, it is an area that is nearly impossible to achieve pressure hemostasis. This can lead to significant buccal swelling and bruising that lasts about 10 to 14 days. But for the vast majority of patients, a hematoma is not dangerous, but it is disfiguring and not something the patient will soon forget. So it will benefit everyone involved for us to be checking for positive aspiration multiple times during the course of a PSA injection to ensure the needle tip has not moved and punctured a blood vessel. Which leads me to my first of two don'ts, and that is don't use a long needle when giving a PSA block, as it is easier to overinsert the needle past the advised 16 millimeters for the average-sized patient. Overinsertion increases the risk of damaging a blood vessel and causing a hematoma. Only your largest patients may need a long needle for PSA injections to avoid hubbing the short needle in the buccal tissue. Contrastingly, my second don't is to prevent underinsertion of your needle during IA block injections. So don't inject for an IA block without first contacting bone. This ensures our needle tip is not too far medial and possibly injecting into the parotid gland, which contains the facial nerve. Anesthetic or pressure from a hematoma on the facial nerve causes temporary facial paralysis of the affected side. Now that we've brushed up on some basics, I'd like to present a few of the local anesthesia techniques we've been taught this past year. We've all had hard-to-numb patients that just don't seem to respond to normal local anesthetic protocol. So, what do? One technique we use at the AEGD is called the triple cocktail. And no, not that kind of cocktail. It's a combination of mepivacaine, lidocaine, and articaine given in succession. You begin by performing a block with one cartridge of 3% mepivacaine and waiting 2 to 3 minutes for onset. This will provide some initial relief if the patient is in pain and begin to reduce anxiety, making following injections easier. Mepivacaine without a vasoconstrictor also has a higher pH than lidocaine with epinephrine, so it has a slight buffering effect. Next, the same block is given with one cartridge of 2% lidocaine, 1 to 100,000, then wait another 2 to 3 minutes for onset of action. Lastly, about 2/3 of a cartridge of 4% articaine, 1 to 200,000, is infiltrated around the apex of the targeted tooth. The remaining third of the articaine is given as a block. At this point, you can also use your finger to massage the infiltration site for about a minute, assisting with diffusion into the bone. While anecdotal, this technique has worked for me many times, and I may have gotten a bit of a placebo effect if the patient knew they were getting a combination of multiple different anesthetics. And in this scenario, a placebo effect is better than no effect. Next, let's talk about buffering. And no, I'm not talking about a bad Wi-Fi signal. I'm talking about buffered anesthetic. We have begun using Buffer Pro in our clinic as an adjunct in our anesthetic toolbox. Buffer Pro is a small single-use vial of sodium bicarbonate solution that is injected directly into the anesthetic cartridge before loading the syringe. It raises the pH of anesthetics with epinephrine from approximately 4.5 to near physiologic pH of 7.4. Studies have shown that buffered anesthetics cause less of a burning sensation on injection. Buffering your anesthetic also allows it to enter the nerve cells faster, meaning a faster onset of action that allows you to start the procedure sooner. The last anesthesia technique I will cover is the AMSA block, aka the anterior middle superior alveolar block. This block is not as widely used as others, but it is unique in that it can achieve anesthesia of buccal soft tissue, palatal soft tissue, and maxillary incisors and premolars, all from a single injection site. An added benefit to this block is that it does not numb the upper lip, so an accurate smile evaluation can still be done even after the full onset of the anesthetic in anterior teeth. This block is best done using a digital anesthesia system since the dentist injects into the sensitive palatal tissue. At the AEGD, we use the WAND STA system seen here that allows us to precisely control the flow rate of anesthetic to make the injection as painless as possible. We complete the AMSA in 3 steps as demonstrated on a patient who needed a small buccal and palatal flap raised, but did not want her lip to be numbed. First, a palatal anesthesia device is placed on the target site, which is a spot even with the contact point of the premolars, and halfway to the mid-palatal suture from the gingival margin. The instrument is held to the tissue with moderate pressure for 5 to 10 seconds. Second, the needle tip of the wand is held so that the bevel is flush with the tissue and a few drops of anesthetic, in this case articaine 1 to 200,000, are administered. Third, the needle is tipped 45 degrees to the tissue and anesthetic is slowly administered while the needle is advanced, following the anesthetic pathway. By the end of the injection, you should see most of the buccal and palatal soft tissue blanching and teeth from second premolar to central incisor anesthetized, all from a single injection site. And you can see in this photo, we achieved blanching on the palate all the way through to the gingiva buccal to the premolar implant sites. It is important to note that about 50% of the time, some supplemental anesthetic may need to be administered to achieve profound anesthesia of the teeth. Thank you for your attention. I hope you find some of these tips to be helpful in your practice. A special thank you goes out to Dr. Robertson, Dr. Carnahan, and my assistant Emily for their contributions to this presentation, as well as to my co-residents, Drs. Freeman, Kiefner, King, and Miller, for their help this past year. It really has been a great time. Also, please enjoy this picture of me giving my very first injection as a third-year dental student at UMKC. Look at that steady hand trying to get the needle to contact bone.
Hello, my name is Dr. Bradley Miller, and today I'll be discussing a presentation about a biopsy. The title of this presentation will be called Biopsy Basics. And so first, a little about myself. I grew up in Niles, Michigan, which if we have the Michigan map up there, we're on the southwest part of the state. From there, I went to Michigan State University for undergrad, the University of Michigan School of Dentistry for dental school, and then found my way down here to Kansas. So it's been a very fun year, a lot of change from going from Michigan to Kansas, certainly, but one that I wouldn't trade. On the bottom left of the screen down there, that's a picture of me doing my first filling. So I figured, this is an end of one chapter of my dental career, and that was the very beginning of it. So in that picture, I don't know who's more scared, me or the patient that I was working on. But we'll get to the presentation next here. So today I'll be highlighting one of the many great experiences that I had at the WSU AEGD residency, which was performing a biopsy. The biopsy that I completed was for an irritation fibroma, and because it is one of the most common benign lesions of the oral cavity, it's helpful to understand a technique to manage it as a general dentist. To start, here's some background information on this type of fibroma. While it is a slow-growing lesion, it is not a true tumor, but instead a reactive lesion that develops in areas of repeated trauma. This can occur anywhere in the mouth, but is typically seen on the cheek, tongue, or lip. These areas are commonly bit by patients. It commonly occurs in the 4th to 6th decade of life and occurs more frequently in females than males. The good news is that recurrence is rare, which brings us to the clinical case that we'll be discussing on the left of your screen. This patient presented with a smooth, pink, well-circumscribed sessile nodule that was roughly 5 millimeters in diameter at its widest point and located on the lower lip. This lesion had been growing for the past couple of years and was becoming a nuisance when the patient would bite it, so they wanted to have it removed. The differential diagnosis was an irritation fibroma, mucocele, or minor salivary gland tumor. When removing a lesion, it should always be biopsied and sent for evaluation to ensure the proper diagnosis. In dentistry, there are generally 3 types of biopsies that are performed. The first type is an excisional biopsy, where the entire lesion is removed and 2 to 3 millimeters of healthy tissue is removed around the lesion. This is typically reserved for cases smaller than 1 centimeter. The incisional biopsy is for when lesions are greater than 1 centimeter, are in risky or hazardous locations that make full removal hard to achieve, and when there is a need to check for malignancy. The final type of biopsy is an aspiration biopsy, which is used to explore whether a lesion contains fluid at all, or to test the fluid for pathologic diagnosis. For this case, because the lesion is smaller than 1 centimeter, we performed an excisional biopsy. The first step in any biopsy is anesthetizing the patient. In general, it is beneficial to perform a block if you are able to make sure that anesthetic isn't incorporated into the surgical site. If you are going to place anesthetic close to the lesion, though, it's important to eject at least 1 centimeter away. In this case, 1/4 of a carpule of 2% lidocaine with 1 to 100,000 epinephrine was placed locally at least 1 centimeter away from the lesion where the red arrows are pointing to on your screen. This slide provides a diagram that shows the shape of the incision below the lesion. Ideally, we would like to see the incision be 3 millimeters away from the lesion and be elliptical in shape to promote primary closure when a suture is placed after it is removed. One technique to assist in the removal of this lesion is a traction suture. The traction suture provides a way to hold the tissue in place while the incision is made so that there is no distortion of the tissue. The image to the right shows the traction suture in place. The diagram on the left shows the placement of the suture below the incision line. There is no defined depth that the suture needs to be placed, but instead, it just needs to be deep enough to help incise the lesion without pulling through and damaging the tissues when tension is placed on the suture. This picture shows the incision taking place with a number 15 blade and the traction suture gently pulling on the tissue. For me, this was the most difficult part and took me a couple tries to not cut the suture when removing the lesion. Dr. May was working with me on this case, and so I thank him not just for his help, but also for his patience with me while I continued to cut the suture with the scalpel. These images show the patient's lip after the lesion was fully removed and ready for suture placement to reapproximate the tissues. When suturing, primary closure is the goal, and the diagram to my left is my attempt to illustrate the tissues being reapproximated after closure with a suture. Ideally, a resorbable suture would be used in this case to give precise tissue approximation. We placed one simple interrupted suture and were successfully able to reapproximate the tissues. Once the lesion has been removed, care must be taken to preserve the histologic and structural integrity. Great care must be taken to not crush the specimen at any stage prior to it reaching the pathologist. The specimen should be placed in a solution of 10% formalin, and it's important to ensure that the specimen is in the formalin when it is placed in the vial and not stuck to the side of it. Be sure to place the patient's name and provider's name on the vial as well. In our case, we sent it to the pathologist at the UMKC Dental School. In addition to the specimen, you will fill out a biopsy request form. This form should include standard information such as the patient's name, date of birth, and a description of the lesion, and working diagnosis. In addition, depending on whether the lesion is in soft tissue or hard tissue, a high-quality image or radiograph is necessary. It's important to get the patient's medical insurance information as well because a biopsy is often billed under medical insurance rather than dental insurance, so patients should be aware of this. Most labs will have the results back in 1 to 2 weeks following receipt of the specimen. If the patient's sutures require removal, this would be a good time to reappoint the patient and go over the results. In our case, the results came back as expected, but it's always important to continue conversations with the pathologist if results come back that don't match up with your clinical impression. Thank you for taking the time to listen to just one of the many fun cases I was able to complete while being a resident here at Wichita State. I thoroughly enjoyed my time in Wichita, and I'm looking forward to continuing my career in private practice. Special thanks to Nick, Lizzie, Claire, and Emma. I could not have asked for a better group to go through this year with. You four were the best part of my program, and I can't wait to see where your careers take you. I'd also like to thank again Dr. May for putting off being fully retired to help us with our classes in cases like the one I presented today. I'd also like to extend a thank you to Tanya, who is my current assistant, for all of her hard work and dedication to our clinic, and all you do to make my life easier every day.
Hello, my name is Claire Freeman. Today we'll be discussing fixing fragile foundation, some tips and tricks for restoring weakened dentition. Before we get started with the case, I'll share a little bit about myself. I'm originally from Olathe, Kansas. I went to school at Creighton University and then went to the UMKC School of Dentistry for dental school. I currently live in Wichita with my pets, Maple, Atlas, and Milo, and my husband, Connor. Next year, we're planning to move back to Overland Park, where I'll be working for a private practice. One of my favorite memories of the year was having my co-residents at my wedding in May. It was really lovely to have all of them there and share that special day together. All right, on to our case. So our patient is a healthy young male. He has excellent home care, is very consistent with recall appointments. But there's more to this story than meets the eye. If we take a closer look at the FMX, we can see evidence of extensive dental care. Our patient experiences tooth sensitivity, has numerous root canals, and many large composite restorations. If we zoom in a little bit closer on the patient's maxillary anteriors, you can see just how much dental work our patient has had. Our patient's chief complaint was concern for the aesthetics and the strength of these front teeth. So why does the patient with seemingly perfect oral hygiene have such extensive restorative work? The answer lies in our patient's dental development. Our patient presents with hypo or undermineralized enamel. Shown here is an image with a very similar clinical presentation to our patient's unrestored teeth. You can appreciate the chalky white spots, yellowing, and mottled pattern that were also present in our patient. Patients with hypomineralized enamel are prone to hypersensitivity of the teeth, rapid tooth wear, poor aesthetics, and frequent dental problems like caries, infections, and failure of restorations despite their best efforts to keep the teeth clean. So what can we do to help our patient achieve their desired aesthetics and also contribute to the overall strength of their dentition? Resin restorations, like our patient currently has, can temporarily help to improve the look of the teeth. However, research has shown that indirect restorations, like all ceramic crowns, are going to have better long-term success than direct restorations. In this case, we elected to restore teeth 6 through 11 with full coverage zirconia crowns. Next, we'll go through 4 tips to keep in mind when you're restoring weakened dentition with fixed restorative work. Tip number 1, you're going to etch to find enamel. This tip has to do with the preparation of the teeth. When you're drilling the teeth in these anterior cases, it's very important to get enough reduction for the restorative material, but at the same time, we don't want to remove too much tooth structure, especially on teeth that are already weak. So one rule of thumb when checking for reduction is to use the patient's enamel as a natural reduction guide. Often, if enamel remains on the tooth, there is further preparation needed. So to check for the remaining enamel, you can use a 37% phosphoric acid etch and apply that to the areas of concern. And as you can see in these images, etched enamel will turn a frosty white color while the dentin remains unchanged. You can then better identify specific areas that are still in need of reduction without removing unnecessary tooth structure. For our second tip, once the teeth are prepped and the impressions or scans have been completed, it's time to fabricate the temporary restorations. Provisionals are very important for anterior aesthetic cases and for those with weakened natural dentition for a few reasons. They allow patients to examine the proposed aesthetics, they allow the dentist to evaluate the occlusion more accurately, and they allow us to make any changes needed before the final prostheses are delivered. The best way to fabricate provisionals for crown and bridge work is by using a lab wax-up. Before the preparation appointment, you can have a lab fabricate a wax-up to your ideal specifications. You can then take a blue bite impression of the wax-up. That gives you a mold that you can use to fabricate a provisional restoration with temporary crown material. After you have made the necessary occlusal adjustments, the patient should wear these temporaries for at least a week and decide if any aesthetic or functional changes are needed. Once you have provisionals that both you and the patient are happy with, you should then take an alginate impression of the provisionals in the mouth and send that to the lab. They will use this cast as their go-by for the final restorations. You'll end up with final restorations that both function perfectly and fit the patient's desired aesthetics. The third tip has to do with the restoration design. When you have weakened enamel, it can be useful to splint single crowns together for added strength of restorations. However, this decision is very case-specific. Some factors to consider are the strength of the underlying dentition. In this case, it's heavily restored and endodontically treated. The patient's occlusion, or if they have any parafunctional habits, and whether or not the patient has good oral hygiene. Because our patient's teeth are heavily restored, he has a history of bruxism and has excellent home care, we elected to splint together crowns 6 through 8 and crowns 9 through 11. And here you can see those final restorations cemented in place. The patient and I were both very pleased with the outcome. And our final tip is to remember to fabricate an occlusal guard for all patients who received anterior fixed work, especially those who already have a fragile foundation. Having the patient wear this appliance nightly will help increase the longevity of the restorations. Here at the AEGD program, we have the SprintRay 3D printing system that allows us to fabricate occlusal guards for our patients in-house. We also use this technology to print our own implant surgical guides, make study models, and a lot of other stuff too. Thank you so much to Machen for all of your help with the technology in the office this year. And a few other special thank yous. First to Dr. Elledge for his mentorship throughout the year, and with this specific case, it's been a pleasure learning from you. And thank you to my wonderful assistant, Kathy, for being extremely patient, kind, helpful, and for always keeping the clinic stocked with the supplies we need to best serve our patients. Thank you all for watching.
Hello, my name is Dr. Lizzie Kiepner, and I will be presenting on custom impression copings for dental implants, specifically when they are indicated and how to make them. But first, a little bit about me. I'm from Southeast Missouri, and I went to dental school in Kansas City, where I will be returning to join a private practice in August. I'm also recently married as of April to my husband, Jamie. And this is my number 6. He's named so because he's my first canine, and because I guess I love a good dad joke. These are a few pictures of us at the Great Plains Nature Center, which is one of our most favorite places in Wichita. Okay, let's jump back into dentistry. So for those of you who may not know, an impression coping is a small component that allows us to capture the shape of a patient's gums and the implant abutment while taking an impression for making an implant crown. We can often use generalized stock impression copings like you see here. However, custom impression copings are helpful for anterior cases where the aesthetics are more important. This is my patient with the custom impression copings in place. Number 7 through 10 were extracted and implants were placed in spaces number 7 and number 10. She wore a temporary fixed partial denture for 1 month that shaped the gingival bowl around her implant crowns. For the best aesthetic result of the final prosthesis, we used custom impression copings to capture her new gingival contour exactly and reduce the likelihood of black triangles. So why are they important? First, they provide a way to communicate with the lab that we created new gingival contours with the provisional resin restoration and that they need to incorporate the new emergence profile in the final ceramic one. Secondly, it aids us in fabricating restorations that are beautiful but also easily cleansable. Specifically, it helps us eliminate black triangles between teeth and ridge-lap contours of crowns. Finally, they can help us overcome restorative challenges. For example, my patient had a limited amount of vertical restorative space, and she had a very low floor of her nasal cavity. To prevent fabricating short, ugly crowns, the lab fabricated a provisional restoration with ridge-lap contours. You can see here in my doodle that the crowns hug the gingiva, giving it some length and making them look more like natural teeth. However, the floss demonstrates that the patient would not be able to clean underneath the bridge. Thus, the bridge design will ultimately lead to inflammation and implant failure. Therefore, we must change the contours before making the final fixed partial denture. So here we added composite resin material to the underside of the resin provisional restoration to make it more convex, but it still adapts to the gingiva on the facial aspect of the restoration for adequate aesthetics. This is called the modified ridge lap design. This is a closer look at the new convex shape of the provisional. Here we can see that the new shape of the provisional does in fact change the contour of the gingiva. Notice the blanching around number 10. So we've overcome the restorative challenges, but now we need to communicate the changes to the laboratory. So how do we make custom impression copings? The first step is to screw down the provisional bridge to the cast to finger tight. Then, you'll place clear impression material around all surfaces of the restoration to capture the gingiva. Remove the provisional and insert the impression copings. Then, place flowable composite around each coping at the base and cure. It's important to use clear impression material so that the light will cure the composite through it. Remove the copings. You can see that we captured the gingiva shape. Insert the copings into the patient's mouth and take a radiograph to verify complete seating. And finally, take an impression. We used an open tray technique, meaning the impression copings come out with the impression. You can see the composite material in the impression, providing the emergence profile of the implant crowns. Reinsert the provisional, fill it with Teflon tape and composite. Patient will continue to wear the provisional until the final prosthesis is fabricated. This was the delivery of the final ceramic fixed partial denture. We were able to communicate with the lab our desired changes in the contour of the restoration, and we achieved a cleansable aesthetic result that the patient loved. And this was the final delivery. I wanted to thank Dr. Hagen for working with me on this case. He placed the implants and he helped me with both recontouring the provisional and fabricating the custom impression copings. I would also like to thank Mindy for being an amazing assistant. It's been a pleasure working with you, and thanks everyone for listening.
Hi, my name is Emma King, and next we're going to be chatting about precision and provisionals. I'm originally from Michigan and completed both my undergraduate studies in dental school at the University of Michigan, where I also met my amazing husband, Josh. Go Blue. While I'm not from Kansas, I have roots here. My mom grew up here in Wichita, and my grandfather worked in Wichita as an architectural engineer. One of my favorite parts of this year has been connecting with that history, including a visit to the Frank Lloyd Wright Allen House here in College Hill. Outside of clinic, I enjoy traveling, DIY home projects, and spending a fair amount of emotional energy on Michigan athletics with Josh and our 2 dogs, Barley and Riley. Meet patient B. He came into clinic ready to complete his last quadrant of implant-supported bridges. He had 3 quadrants completed by previous residents and was eager to get back to full chewing power. We'll use his case to explore a diagnostic step that saved time and improved the final result, provisionalization, and address some key elements we don't want to forget about when designing implant-supported prosthetics. So, why provisionalize? I'd like to suggest 3 reasons: aesthetics, occlusion, and the unknown. While aesthetics are often top of mind, especially in anterior cases, provisionals in the posterior can help reveal functional concerns we don't always anticipate. In the case of patient B, he told me early on he didn't care if his teeth were blue, he just wanted to chew. Provisionals allow us to evaluate how occlusion holds up under functional load, tongue space, phonetics, and soft tissue response over time. Patient B's provisional seemed great at delivery, but living with it revealed an issue we hadn't detected that day. That's the value of addressing the unknown. Sometimes patients don't know what they feel is off until they've lived with it. At delivery, patient B gave the provisional a glowing review and asked why it couldn't be the final. But a week later, he returned and said, "The bridge feels like it's in the way of my tongue when I talk." There was no occlusal discrepancy or mobility. The issue was phonetic, caused by an excessive contour on the lingual aspect of the bridge. This type of feedback highlights how important provisionals can be when we're assessing the intraoral spatial dynamics, particularly in multi-unit posterior cases where tongue mobility is easily affected. Let's shift to implant occlusion. Implant-supported restorations require a different occlusal philosophy than natural dentition. Unlike natural teeth, implants lack a periodontal ligament, so they don't absorb force or provide proprioception. Any discrepancy translates into direct biomechanical stress. The goals of implant occlusion include lighter contact and centric occlusion. In light-centric, we want to see shim stock holds on natural teeth and drags on implant crowns. In heavy-centric, we should see a hold on natural teeth and implant crowns. Axial loading. We want implant restorations to direct force axially to reduce oblique stress and micromovement. Non-axial forces can stress the prosthetic components. Once we've identified areas of our implant restoration that may need occlusal adjustment, we can use a great technique that Dr. Elledge has shared with us this year, occlusal indicator wax. You place a strip over the occlusal surface and have the patient tap and grind. The resulting perforations show clear, high-resolution contact points, better than articulating paper alone. Marking areas of burn-through with graphite allows for efficient and accurate adjustments. In the case of patient B, we used a splinted bridge from number 3 to 5, which has benefits in the posterior maxilla where bone density tends to be lower. This brings up an important question. Should we splint implant crowns or keep them individual? Splinting distributes occlusal load, reduces micromovement, increases long-term screw stability, and may preserve bone. Downsides include more challenging hygiene for patients and more complexity in achieving passive fit across multiple unit restorations. So, the decision to splint should consider patient hygiene, compliance, bone quality, and prosthetic and force dynamics, all of which can be tested in the provisional phase. For splinted restorations, abutment selection is an important restorative consideration. Abutment selection often comes down to balancing rotational stability with the path of draw. Engaging abutments offer rotational stability and are ideal for single units, but can complicate seating in multi-unit cases due to potential divergence or convergence of the implants. Non-engaging abutments simplify insertion and reduce internal stress in splinted prosthetics. A hemi-engaging setup using one engaging and one non-engaging can balance rotational stability and passive fit. Choosing the right combination helps us avoid complications later. Once our design is finalized, the next step is sealing the implant screw access. When short-term retrievability is needed, light body PVS is a quick, effective option. Light body PVS is injected into the access channel, and the excess can be cleaned off with a microbrush. At the time of removal, the PVS can be removed with an explorer like a cork. This method requires no drilling, thus reducing the risk of damage to the screw and requires less shear time. This method is ideal for provisionals or cases where reentries are necessary in the short term. For long-term sealing, we want aesthetics and retrievability. Yellow Teflon can be placed over the screw for anterior restorations, which will minimize color show-through. In the posterior, blue Teflon can be used, which is easier to identify during reaccess. Both are sealed with composite that's matched to the implant crown. This approach gives us durable, aesthetic finish and a visual cue if reaccess is necessary. So, in summary, even with precise implant placement and beautiful prosthetics, success sometimes hinges on giving patients time to live with the restoration. Provisionals allow us to fine-tune aesthetics, assess function, and discover the potential unknown. I'd like to say thank you to our program manager, Amanda, for your steady leadership and support throughout this year, despite your incredible workload with accreditation. I'd like to say thank you to Veronica for being such a positive and dependable presence every day. You're an incredible advocate for our patients and a great team member. And I'd like you to say thank you to Dr. Marr for your calm mentorship and for giving us confidence in our work while also pushing us to grow.
As water shapes the rock, so one person shapes another. That is the idea behind our rock exchange ceremony. Turbulent water shapes and smooths the stones in a mountain stream. In the same way, so too have our residents been shaped and smoothed by the knowledge they have been given throughout the last year, transformed from rough stone into a gold standard, ready to teach others. However, just like these stones, none of us is ever finished with our journey of transformation. We all remain at least partially unfinished, always ready for more knowledge. With the rock, there is a natural hole. That means go forth and shape others. Congratulations, Dr. Claire Freeman. The rock, David? Thank you.
Thank you.
Congratulations.
Thank you.
Next up, Dr. Emma King. Congratulations.
Yeah.
Congratulations.
Thank you.
Next up, Dr. Nick Desh. Congratulations. Congratulations, Dr. Desh. Thank you. Next up, Dr. Brad Miller. Thank you, Dr. May.
Congratulations. Thank you.
Next, Dr. Lizzie Kiefner. Congratulations.
Congratulations, Lizzie.
Thank you.
Each year, we pass the torch to a new round of residents. Join me in welcoming our next group.
Hi, my name is Dr. Eric Wind. I'm originally from Denver, Colorado. I recently graduated from dental school at A.T. Still University, Missouri School of Dentistry and Oral Health. I'm really excited for this next year at this AEGD. I'm really excited for the opportunity to get my hands wet with advanced cases, especially doing some advanced restorative cases on patients. I'm excited to be working with my team for the next year.
Hi, I'm Dr. Monica No. I'm originally from Leesburg, Georgia. I graduated from the University of Buffalo School of Dentistry recently. I'm really excited to be here in Wichita, Kansas, and I'm excited to learn more about advanced dental techniques in this upcoming year, and I'm looking forward to working with my team.
Hi, I'm Dr. Cheyenne Cornwell. I'm from West Palm Beach, Florida. I just graduated from the University of Florida College of Dentistry. I'm really excited to expand my clinical practice over the next year. One of the things I'm excited about learning are more advanced endodontic techniques.
Hello, I'm Dr. Ahmed Arawi. I'm an UNLV graduate. I'm really excited here to be learning about endodontics and more advanced cases, and hopefully we'll enjoy this year.
A program like ours is only possible with the help of so many amazing people. I can't thank everybody, but I would like to take a moment to mention at least a few. First, our managers, Machen Johnson and Amanda Connor, as well as Krista Hollinger at reception. They have helped make all of this possible. Our amazing dental hygiene team, Sierra Bradshaw, Lisa Curran, and Rosie Pino. To our oral surgery specialists, Dr. Larry Evans and Dr. Chris Harris, they've made Wednesdays so incredible. Thank you for your knowledge and consistency. Also, thank you to Dr. TJ Foley, who provides endodontic support, and also we love the random texts of support to our residents. A word of thanks to Jason Wagle, Mark Hagan, and their team for their periodontal expertise. I would like to thank our general dentistry team, Doctors Traiani, Carnahan, Marr, and Robertson. You've been instrumental in shaping these residents as well as me. And a final special thanks to Dr. David May, our Assistant Director. You've been here from the beginning, and your unwavering support has meant so much to me over the years. To these and so many others, thank you for your continued support. And a special thank you to everyone watching. It's been a great year, and we can't wait to see you again next year.